You can start, madam. Yes.
Okay.
Okay.
Okay. Okay. Hi, good morning, everyone, and welcome on this wonderful Sunday morning. Thank you, everyone, for joining in. This is Dr. Gauri Kulkarni, President of Thane Academy of Pediatrics 2025. Thane Academy of Pediatrics is getting you and bringing you this extremely interesting, interactive, and one of its kind webinar where we are addressing common questions which all our parents face. So, morning, fellow pediatrician, doctors, and parents of my little patients. Our motto for this year, Thane Academy of Pediatrics motto for this year's Reach the Unreached. And this is not only for the patients, reach the unreached, even as far as our questions are concerned. So something which always is playing on our minds, we are getting it to the forefront. Okay. And we have wonderful, wonderful speakers here. Now, there are few problems which trouble us. माझा मुलगा सदैव खोकतो. मेरी बेटी हमेशा खांसी करती है. My child is constantly coughing. What is the myth and what is the truth? So because of this, yes, grandparents too. Yes, Tanuja. So what do I need to do in this scenario? And is this something very serious? Is this treatable? Is this
public
chronic?
program काय
Can I
ठेवलाय?
do
Allergies
something
in
else?
children.
Now, what do we do? Ranjana, please mute yourself. Ranjana, please mute yourself. Dr. Ranjana Pandey, thank you so much for joining. Please mute yourself. We have so many questions in this. मेरी बेटी बहुत खांसी करती है. Is this going to be chronic? Is this going to be treatable? What can I do for this? And to address all these questions and many much more, which we have in our minds, we have two very senior pediatricians from Thane Academy of Pediatrics joining us. Amrita, can you please share the slide? Mr. Santosh Agarwal, please mute yourself. Amrita, can you please share the PPT? Dr. Amrita Durge. My Constantly Coughing Child, Myth versus Truth by Thane Academy of Pediatrics. We have with us our Diggaj speakers. Amrita, Dr. Amrita, the PPT about the speakers, please.
Are you able to see the presentation, ma'am?
Yes, yes, I can. Yes, I can. The next PPT showing all of us. I am your host and host, Dr. Gauri Kulkarni, President of Thane Academy of Pediatrics. I'm a senior consultant pediatrician with my own clinic. I'm an attached also to MRR Children's Hospital and Bethany Hospital at Thane. Yeah, our speakers. Panelist, Dr. Prakash Vaidya, sir. He's a senior consultant pediatrician and at Fortis Hospital with a special interest for so many years in respiratory medicine and sleep medicine. We also have with us Dr. Archana Kavalkat, ma'am. She's treasurer of Thane Academy of Pediatrics for 2025. She's a senior consultant pediatrician and head of department at Curio Hospital, Thane, and a visiting consultant at Jupiter Hospital, Hiranandani Hospital, and MRR Children's Hospital. The fourth one on the list is our extremely dynamic moderator, Dr. Amrita Durge, who has really burnt the midnight oil to get this presentation across to all of you. She is an executive board member of Thane Academy of Pediatrics. She's a consultant pediatrician with her own clinic, Heal Thy Clinic and Heal Thy Kids Clinic. Also a consultant at Bedekar Hospital and Kaushalya Hospital, Thane. So without much ado, let me hand over the proceedings to Dr. Amrita, who will then take on the questions for Dr. Prakash Vaidya sir and Dr. Archana Kavalkar. So this is what it is. And this is how our plan of action would be. Questions to the panelists and discussion. Then we're going to have demo videos, which are very interesting and exciting to see. We're going to have a response to chat questions, and we will have our concluding remarks by Vaidya sir and me. Please put in your questions which are relevant in the chat box. If there are few questions on the same lines, we will all club them together and ask. So here goes. I will mute myself and hand over the proceedings to Dr. Amrita. Thank you very much and welcome all again.
Thank you, Dr. Gauri Kulkarni, madam. A very good morning to all of you, all the parents, the doctor parents who have joined us, all the grandparents who are here, and I welcome and thank my panelists and also my host, our president, Dr. Gauri Kulkarni. So, friends, as the plan has been laid out to you, let's quickly start over with our discussion with our panelists. Let's start with two of very common scenarios. Okay, you all must have experienced this. A 3-year-old girl with repeated coughs and colds since her daycare has started. Uh, Many times there has been fever, but the coughs and colds have continued even when there was no fever. And the cough has lingered for many days despite taking regular medicines. And then there could be another scenario where it's a 2.5 year, 3-year-old boy who has had persistent mucus congestion and cough, and it has all started after the Diwali of 2024. In fact, it was his first Diwali to have experienced all of those firecrackers and going out and enjoying the fire play. Again, this boy also had fever sometimes, and even when the fever was gone, there was persistent symptoms. Also, his sleep is being disturbed because of the cough. So, Dr. Prakash Vaidya, sir, my question to you, are these infections every single time, or is my child allergic to something?
Yeah, a very good morning, and I really thank all the parents for sparing a part of the Sunday with us. So nice of you. So we have these very common scenario when a child who goes to daycare for the first time is exposed to numerous infections. Let me first make one thing clear that when there is fever, it is more likely to be an infection as opposed to allergy. But having said that, many children who are allergic, they tend to respond more, let's say, severely to any infective pathogen. So, what happens when your child goes to daycare? He's in an enclosed room, AC is on, and there is a circulation of a virus which one child may carry. So, as a result, most children get repeated infections in daycare, repeated cough and colds. And this is not true only in our country, it's true abroad also. Averagely, they say 6 to 12 infections per year. So that is why many kids who exposed to daycare for the first time or go to nursery for the first time do get repeated cough and colds, and it is not of great consequence.
Thank you so much, Dr. Vaidya. But then, Dr. Archana, sometimes when my child is unwell, I hear a lot of noisy breathing, easy kind of sounds, people say. And my child is also having difficulty breathing, especially during sleep at night. So, what could these be, Dr. Archana?
So, again, good morning, everybody. Uh, these sounds, which are labeled as wheezy sounds, are not always the wheezing that we consider a little worrisome type of wheeze. Wheeze can appear from any obstruction, right from the nose to the lower parts of the airway. This is a look at our airway. This is the nose. Your nose, especially the younger child's nose, is full of secretions, especially the younger ones, where the nasal passages are very narrow. Any nasal mucus stuck there will be making those kind of sounds. I hope you can hear, that kind of a sound, which makes the parents feel that this is a wheeze. As the obstruction or the mucus goes downwards, it can make some throaty sound. So those are also referred to as wheeze. But when we are talking about wheeze, that this is coming from the lower passages, which we will show you just now. They are the trachea and the major passages which are lower down when we call it really wheeze. The other sounds, they could just be a nasal blockage, which can be relieved with plain nasal saline drops.
Right.
So I'll add to this a little that when parents loosely say it is wheeze, my child is wheezing, we are not 100% sure till we actually examine the child, because a lot of these upper airway sounds can be mistaken as wheezing by the parents.
Amrita, one point I wanted to make was, please, if the parents are not sure, take a video of what has happened at the night.
Absolutely.
So it really helps us to pinpoint the cause.
Absolutely. Yeah. So, Dr. Vaidya, my child had fever, cold, and cough. and his pediatrician had advised syrups initially, but the cough lingered for many days even after the fever was gone, again disturbing his sleep. So on checkup, again when we went back, doctor mentioned that he has wheezing and advised inhaler. Does that mean my child has asthma, Dr. White?
Yeah. So I think one thing I would like to make clear that the drug or the delivery system does not define the disease. Meaning that just because you are using an inhaler does not by default mean that there is there is definitely asthma. Let me give you a simple example. I think there is.
ये डॉक्टर्स की
Please.
मीटिंग है
Uh,
and
Anand,
they're
Dr.
the
discussing
Anand, can
about
you
profile
coughing
named
insulin.
the profile with the name Lavi. Can you please mute yourself? The profile name Lavi. Dr. Anand, can you help us mute?
I
Thank you. Dr.
So,
Vaidya, please go ahead.
yeah. So basically, what happens is that let's take many of us do give ibuprofen syrup to our kids, ibugesic as one of the brand names. Now, this syrup is used in a variety of conditions. It's used in fever, it is used in pain, it is used in arthritis. It can even be used for a pain related to a malignancy. So, does it mean that by using this, your child has a particular disease? Not at all. Similarly, usage of an inhaler means you're only using a particular delivery device which delivers the medicine to your airways. It does not by any means define it as asthma. In fact, I would go so far as to say that the majority of young children who are on inhalers are not really asthmatics.
Right. So parents, please make a note. Having an inhaler in your prescription by your doctor should not immediately scare you with the diagnosis of asthma. Dr. Vaidya sir, can you explain to us what exactly happens during wheezing? Let me help with this diagrammatic pictorials.
So what
As you
happens?
explained.
Wheezing is basically simple. Wheezing is something that you hear. It's a sound of which is a sound of a particular pitch which the clinician hears on auscultating with a stethoscope. But what the sound is generated because the normal airway diameter is reduced. The airway gets narrowed. This narrowing can be due to two reasons. One, the muscles of the airway go into spasm, they become tight and reduce the airway diameter. And the second reason is that the airway gets inflamed from inside, full of swelling, full of secretions, and that also narrows the diameter of the airway. So basically, wheezing reflects a
ट्यूसडे की मंडे
narrow
को पेस्ट
airway
कंट्रोल
diameter, which can be due to any of these
कल
mechanisms.
वो वही बोल रहे थे कि कल ही
Audiences,
बुला लेना
please
मंडे
mute
ट्यूसडे ज्यादा
yourself.
लेट हो जाएगा
Yeah, I think
Audiences, let me request you again, please mute yourself so that we all can hear the experts, all the
तो अभी
iPhones.
सभी चेक कर लिए
Dr. Nandini Shah,
ये
Dr. Nandini Shah, may I request you to please mute yourself? Thank you. Yes.
Yeah. So an airway that is, so in a wheezing, the airways actually become very narrow, either because of muscle spasm or something inside the airway lumen or a combination of both factors.
Right. Okay. And then what could be the symptoms, sir, which can be bothersome where the parents have to go back to the pediatrician for follow-up?
When the airway is narrow, obviously the child's oxygenation suffers. So the child start feeling breathless. How do you know that your child is breathless? His abdomen may be heaving. The chest wall may be moving faster than normal. The nose may start the flaring up. And the child coughs because of the airway spasm. If it's an older child, he'll say, I have a feeling of chest tightness. I feel tight in the chest. And in a severe wheeze, you may still hear what is called as an audible wheeze. That means the wheezing may be audible to the naked ear. So all these features or a combination of them or some of them can suggest that the child has an airway narrowing, which we call as wheezing. Also, many children who wheeze are not ready to do any activity because by doing exercise, by starting any activity, the wheezing worsens. Also, this wheezing tends to interfere with sleeping at night as well.
So even when a small child is playing, for example, the child may have more frequent cough or have a heavy breathing.
A child may be fine at rest, but once he starts running and playing, he may start having cough as well as heavy breathing.
Right.
So this suggests that there is exercise triggered wheezing.
Right. And Dr. Archana, can you tell us if it's a very small child, an infant, so what could be the findings that the parents can observe to understand that things are probably slightly more severe? Dr. Archana.
So first and foremost, I'd like to tell the audience that even older than 2 years, kids sometimes just carry on with their activities, and it depends a lot on the parents to judge if your child is breathless or not. Like sir said, the various points that were mentioned in an older child. In a younger child, they're even more unvocal, or they do not express their difficulty at all. So these children, you would find their chest is getting pulled inwards, like is indicated here in the picture. The ribs are literally moving up and down. The muscles are getting drawn inside. They are breathing very fast, sometimes at the rate of more than 60 breaths a minute. Their nasal, the ali are, moving up and down. So literally their neck muscles are prominent and leading to the head going this way. That means that the child is really breathless. This child will refuse to feed. This child will be extremely cranky. And in fact, when the child becomes very quiet, that may be a time to really worry about this child.
Right. So we are
I may
basically
just add
talking.
one sentence
Yes.
is that when the child does not sleep well at night, and when the parent report that, I take it much more significantly that my child did not sleep last night because of the wheezing. Yeah.
So parents, again, make a note. We are helping you understand the symptoms as they are in the common viral infections during milder versions of the problem versus when they are going slightly downhill. Okay. Dr. Archana, my 3-year-old continues to cough frequently for almost 2 to 3 weeks, even after a viral infection is over. And he responds to inhaler. Does it mean my child has low immunity? And can I help my child with some homemade remedies like kadha or something else for this low immunity?
So first and foremost, again, you have to understand that this concept that if a child is coughing a lot and this cough is going on, his immunity is low. It is wrong. When you're talking about immunity, we are talking about immunity with respect to infections. So if your child is getting repeated fevers, virals, that's a child whose immunity is low. But 6 to 12 infections are just normal in the younger children. Now, a child coughing only and coughing for a longer period of time is not because of low immunity, it's because of a air passage or air tubings which are hyper reactive to the stimuli, or they are too sensitive to the stimuli. And so this cough can go on sometimes for 2 to 3 weeks. Coming to your next question, the kadha, etc. Kadhas, etc. are probably helpful for more like throat pharyngitis, throat infections, which we call, where the throat irritation is responsible for the cough. So for this, maybe it may be helpful, but for coughs which are going beyond 2 weeks after a viral infection, which respond to inhalers, definitely this child falls in the category where he may need or she may need inhalers for a longer period of time.
Dr. Vaidya, my question to you. So if it's a small child, we're talking about these preschool age groups. So do we call them as having asthma if they're responding to inhalers, or what do we call them?
No, if they respond to inhaler, which contains what is called as a bronchodilator, that means that their airways are responding to this particular drug, which is in a very low dose, but the airways are opening up because of that. However, this is true in asthma, but only a 5 to 10% of such children have asthma because the majority outgrow this airway reactivity after 5 years. So to answer your question, if a under 5 child responds to inhalers or responds to this medication, it does not normally mean that the child has asthma. Only a small minority of those would, but the most of the others, like 80 to 90%, would outgrow this problem by age 5.
Yes, and we are going to come to this part of the discussion a little later for sure. But thank you, Dr. Vaidya. So we have again answered this question. Dr. Vaidya sir has answered. My question again to you, sir. There are so many children being diagnosed with asthma nowadays, but my family has no one who had asthma. So why is that my child is suffering from symptoms similar to it? What could be the causes?
So the first part of my answer was that if it's diagnosed too early, the child tends to outgrow. So it wasn't really true asthma to begin with. But yes, we have a lot of children who are diagnosed with asthma. The key word is diagnosed. Maybe 15, 20 years down the line, it was not even being realized that these children were asthma. So we are now more tuned, we are now more advanced, and we realize it is asthma. We are more accepting. And because of, I think, because of counseling, parents are more accepting. So one, the label has become more accepted. That is one thing. But having said that, there is definitely independently an increased incidence of asthma, and that has to do with our terrible air pollution in our country, the dust, the smoke, an increased number of infections, and something that is underestimated, indoor pollution. What we don't realize that at home also there are so many pollutants. We use agarbattis, we have cockroaches at home, sometimes there are pigeons with pigeon droppings, then we have molds in houses that when there is a leakage, smoking, whole lot of things, chemicals, mosquito repellents. All these things tend to be allergens, which increase the incidence of airway reactivity, airway worse. So yes, there is a true increase in asthma because of all these factors. Plus, there is an increase because of early recognition of asthma. And one more thing is that that does not have to be a family history. It can independently occur without a family history of asthma.
And to summarize again in one slide, what Dr. Vaidya sir has helped us understand, these are all kind of possible triggers. So, Dr. Vaidya, we call them triggers. They can be inside the house or they can be the outside factors also, from pollution till
Yes, so
pollens.
internal and external pollutants are really triggers or inducers of asthma.
Right. Dr. Archana, could there be also the seasonal changes as one of the cause? Because many times this has been seen that children fall very very sick with cough when the season changes.
So there are two things to this. One is one group of children who have asthma, which is an allergic type of asthma. So we have to remember that with every season's change, there are sometimes some pollen which are in the air. Now, pollen that come from grass, from shrubs, from trees which are flowering. So these come in a seasonal fashion. So very often, parents and even the caretakers do not realize that there is a tree outside the house which is throwing out the pollen every time that happens. This child is coughing. So those are the ones who are probably allergic, and hence we label them as seasonal change.
Right.
There may be children who just respond to the change in the environment in terms of the musty weather, in the rains. Maybe this is associated with molds which are there on the walls, so they may be contributing. The molds may be contributing. Suddenly going into a chill, cold AC environment irritates the respiratory passage. That can be a trigger. So the label
leakages that
seasonal
happen
has
during
to
rainy
be
season.
analyzed very nicely. The seasonal has to be analyzed very nicely. And so we spend a lot of time trying to understand the history of the patient in order to label the cause or find the trigger.
Right. Yes, great. Thank you so much, both of you. Before we move ahead to the next part of the discussion, let's quickly understand what we have learned so far. So, children younger than 5 years may have repeated common viral infections, and majority of them do not have low immunity. Noisy breathing due to nose block is very common. Frequent saline instillation, frequent saline drops in the nostrils are helpful. Watch for wheezing and other symptoms of concern, and wheezing is that typical whistling like sound that can be felt on the chest or on the back, or it can be actually heard also. Cough syrups are not recommended in this age group, and family history of asthma may or may not be present. All right, so moving over to the next section, Dr. Vaidya. My 7-year-old child has had wheezing spells frequently when he was a preschooler. My doctor had advised nebulizations then. Even today, whenever she has certain similar symptoms, I give her the same medicines through nebulizer twice or thrice as required whenever she is wheezing. And I stop them when she gets better. I hope I'm doing the right thing. Parent is asking, Dr. Vaidya.
So let me give you an example. Suppose I had a situation in my house where fires were breaking out every now and then in different rooms. Would I like to just douse the fire for the time being, or would I like a solution where the fire will not occur in the first place? So
Absolutely.
what are you doing with nebulization? You're just dousing your airway reactivity for the time being, but you're not addressing the cause. That is why this is not the right thing. You need to address the cause, and here you need to use a preventive medicine which will not allow frequent wheezing spells to occur in the first place. So I
Right.
think one should be more holistic and do it more methodically with your doctor's advice.
Right. But so nebulization is also a form of therapy, like we discussed that with inhalers, we are, they help child respond better. So is nebulization. So can you elaborate a little bit on how nebulization works?
See, somehow nebulizers have become very popular in our country because they are widely prescribed.
Yeah.
However, the point is that more and more data is now accumulating about nebulizers. There are some downsides of nebulization which we should understand. One, the dose is quite high and hardly 5% goes to the lungs. 90% goes to your mouth, from which it can be absorbed into the system. That is one thing. Second is the drug can go into your eyes as well. And in a breathless child, if you use nebulization without oxygen, the
Right.
problem is that the child may become worse. Not only that, many times the same kit is used without proper look at cleaning the kit, and that kit can get contaminated by germs and cause infection in your child. So
Right.
all these side effects are there in nebulization, which there is a good solution for that, that is called meter dose inhaler.
Right. And also, so these nebulizers are generally the plug-in devices.
Hmm.
So you need to have a plug-in facility all the time when you want to use it.
Yes, that's
Although
true.
there are a few that are now available that are battery operated, but basically the message that we are trying to convey is nebulizer is something that is not the optimum therapy. So then, Dr. Archana, which is then a better alternative of treatment for a frequently coughing child?
So, before I come to that, I would like to say that when you are prescribing an inhaled form of medicine, that is primarily because it is going directly to the site of action, which is in the airway. Whereas when you're prescribing a syrup, goes in a roundabout fashion before it approaches the airway. The dosage that is given in an inhaled form of medicine is far less than the dose that is given in syrup. So that's inhaled medicines versus syrup. Now coming to the other inhaled device, which is called a meter dose inhaler. It's much like a perfume bottle in which in a compressed fashion, this liquid is kept, and it's used. It gives an aerosol form of the drug,
Puff,
which is
maybe.
a puff. Yeah, it's called a puff. You have seen this. Everybody has seen this. And this is the better way to deliver the drug.
Yeah.
And
Parents,
generally, it has to be given with a spacer. Now,
yes, we are coming to that, ma'am. Parents, please note this is a representative image. Okay, there are different colors, there are different medicines that are contained inside. We are simply introducing you to the inhaler. It's also called meter dose inhaler or MDI. Your doctor's prescription might read that. It is also called pressured meter dose inhaler or PMDI. Dr. Vaidya and Dr. Archana, which one is better? We just saw that, and this is a kind of comparison for the parents to understand. Dr. Archana, you were also talking about a direct or aimed at or a target organ thing. So obviously that will lead to quick and maximum relief. Dr. Archana?
so inhalers versus nebulizers now, because obviously the drug is going directly. The drug delivery is definitely better. We said in nebulizer, much of the drug is wasted and going to the wrong place.
Yes.
There is maximum relief which you get with an inhaler, and like we said, the doses are smaller because smaller dose goes more
Are
into the
sufficient?
lungs as
Yeah.
compared to the solution, because
That
large
is
volumes of solution have to be used. And obviously it is not a plug-in device. It's easy to carry, pocketed devices which can be taken here and there, and it is
Dr.
inevitable. There is no
Prakash Vaidya, I
question.
took you to this doctor, Dr. Gauri Kulkarni, our pediatrician.
There
Ramya,
is
can you please
Prakash
mute
Vaidya.
yourself? Ramya, thank
Yeah.
you. Yes, Dr. Archana.
So obviously this device is portable, it's easy to carry, and hence it's a much preferred and safer method of giving inhaled medicine as opposed to a nebulizer.
It is the least
Absolutely.
possible dose that you can give by the inhaled route that can be given, and that dose can be only given by the meter dose inhaler to someone.
Yeah.
Right. Okay. So, Dr. Vaidya, this is an inhaler. We have mostly seen grown-ups take it directly in the mouth. How can a child use this?
So actually, the best way of taking it is via what is known as a spacer. This is true even for adults, but most certainly for children. Now, I have children whom I have put on spacer, and then after some time they say, we are taking it directly. Let me again reiterate that you cannot take it directly because it requires a very high level of coordination, which a child is not expected to have. Therefore, for every child, we definitely use a device with a mask like this or without a mask. But either way, the spacer has to be used because A, it reduces the mouth deposition, B, it delivers the medicine right to the lungs and improves the efficiency and makes the device much more effective and gives you good results. So do not use it without a meter dose, without a spacer at any age in your child. That is my message.
Right. All right. So, parents, let's see how this needs to be used. Let's see a small video. And this is a device that goes with the name Zerostat VT Spacer. Again, just a representative video. Dr. Archana, the video is audible
Yes.
and
It's not audible.
Audio is not there.
Is it not
Kavita,
audible?
you can just tell what she's saying. It's seen, but you can just.
Okay, okay. So these are basically steps in how to use the spacer. So these are the parts. There is a chamber, there is a mouthpiece, and there is a slot where we insert the inhaler. Okay, now let's see the steps. So these two halves are generally assembled first, and it is twisted to lock. We take the inhaler, remove the cap, always first shake it well a couple of times, insert it in the slot, and press that canister to allow a puff inside the spacer. With the mouthpiece, the child has sealed the mouth completely over the mouthpiece and continues to breathe. The spacer and the mouth is closed and the child holds the breath as long as possible and then exhales. This is done 3 to 5 times and the child is guided to breathe as normally as possible. After every dose of medication, we encourage the child to gargle. If it's a very young child, we may allow the child to have drinking water, few sips. How do you clean the spacer? So generally, it is advised to clean once a week at least. Untwist and open the two parts. Wash with simple soapy water and then again rinse with clean water. Check well. Do not use any hot water. Normal tap water is used. And then it is air dried. No need to dry it with a tissue paper or cotton or a cloth. Avoid any fibers. So this is about the Zerostat spacer. There is another kind of spacer and that is called a half puff kit. Many of you might have used this or have heard of this. Let's see a video showing. Dr. Archana ma'am, are you able to hear this audio?
Audio is not heard.
Archana audio is not good.
Let me explain again. So again, another device called half puff kit with a spacer and there is a mask in the front. You can see remaining parts are the same. It comes actually in a nice storage case as you can see in the video. Okay. Let's follow almost a similar step. So inhaler is opened first from the cap, shaken well couple of times, attached in the slot meant for the inhaler. The child is made to sit comfortably with back rested. Slightly hold up the chin and apply the mask, the chin, over the mouth and over the nostrils. It has nice shape. And make sure that it is sealed completely. Continue to let the child breathe normally for 30 seconds. Remember, one puff, 30 seconds. After that, remove it, close the mouthpiece of the inhaler and keep it safely in the storage given. If there are two different medicines or doses prescribed, one puff 30 seconds followed by a break of 30 seconds or a minute and then second dose again in the same fashion. Okay? The cleaning instructions are almost the same. Untwist, open the chamber spacer with normal temperature water, soapy water, rinse with clean and air dry. Importantly, these spacers need to be replaced approximately 6 monthly or when they kind of lose their transparency. And then there are these few other types of inhalers also. We just saw and discussed few common types, but there are different types of inhalers based on the age groups that are used. Okay, let's not go in too much detail of the different types. So, Dr. Archana, again, there are few difficulties in the use of this. So, for example, there is a very young child, a toddler or an infant who is on inhaler with spacer and mask, but parents find it very cumbersome to use. The baby is constantly moving, is crying a lot and coughing a lot and fights with that inhaler use. So parents feel it's a struggle. Or there could be a child who is constantly coughing. So even while the inhaler is on, there is a cough. So how do we manage an inhaler session? Or there is a child who has been on inhaler and one of the doses falls later in the night when the child is asleep. So can one use inhaler when the child is asleep? Dr. Archana.
So, first of all, forgive me, there's some problem. I'm not able to, my face won't be seen, but.
But we can hear you. Please go on.
Yeah. So, first of all, parents have to understand that in order to teach your child something, you have to learn to accept that this is you want to go ahead with this therapy. You yourself have inhibitions about a certain thing. Your child will obviously not going to learn from you. One the younger one or the older one, just to demonstrate how this has to be used, and this makes things because he or she learns that if my mother is being able to use this without difficulty, so can I. Sometimes in the initial phases, by counseling, by talking, a little bit of cajoling, coaxing, you may find it difficult, but eventually I have seen in my experience that children do come around and very happily they use the inhaler. Next question is, when the child is coughing a lot, what do you do? Now, when the child is coughing a lot, obviously the drug delivery is not going to be optimum. But in this situation, with your doctor's advice, the doctor generally advises that you can repeat this puff at 30-minute interval and again 30-minute interval till finally the child starts feeling better, the cough subsides, and then the drug delivery improves. But this is all to be done with your doctor's advice. Last question about the sleep. When you're sleeping, your respiration is actually not, those deep respirations. It may remain shallow. Drug delivery is not optimum when one is sleeping, and hence it may not be the correct time to deliver the inhaler. But yes, if there are really huge challenges, you can give it when your child is sleeping, but obviously this will be only the one with the mask, not the one where the child has to use the zero stat spacer or the spacer directly in the mouth. I hope that answers the question, Dr. Amrita.
Yes.
Couple of quick comments, Amrita. One is that many times parents tell me that there's a big struggle with the child using the mask and kit. My question is that, do you remember when you first started brushing your child? Wasn't it a big struggle? But with time, the child accepted brushing because he knew it wasn't painful. So you have to keep on persisting. Once the child knows it's not going to be a uncomfortable thing, they will accept it, but do not give up because of that. That is one thing. Regarding usage during sleep, basically once if you put the mask too tight, the child may get up, And if you make it too loose, there is a lot of drug leakage. So definitely giving during sleep is a very, very unsatisfactory method, but it is better than nothing, is what I will say.
Right. Okay. Thank you. Dr. Vaidya, when I saw the prescription of my child who's been on inhaler, I saw that there is a steroid in this medication. So, what is cause side effects? What are the medications used here?
So once steroids is mentioned, most of us will have alarm bells ringing that there is a steroid,
Yes.
so it's something very dangerous. Let's understand this in perspective. One, it totally depends on the dose of the steroid, and secondly, the route at which it is used, and thirdly, the time period for which it is used. So in inhaled steroid, the dose is extremely, extremely low. It's not milligrams, it's micrograms. One. Secondly, how is it used? It is used by inhalation. So it goes only to the airways, it does not go much to the circulation. So it is a locally acting drug and therefore hardly has any systemic side effects. That is the second thing. The third thing is that usually we do not use it for years together. It's used only for a few months and then it is reduced in dosage. So in all, the safety of using inhaled steroids is documented. Even if it is used for 10-20 years, there is a documented safety. And finally, most of the time your pediatrician is going to monitor the child. You're not going to use it without his help. So the growth is monitored, the height is monitored, and any kind of adverse effects are monitored and taken care of. So I think
Right.
under supervision, using this low dose of inhaled steroid is absolutely, absolutely safe, and there should be no alarm bells at all.
Right. So when Dr. Vaidya sir mentioned that the dose is extremely low, not in milligrams and in micrograms, just to quickly help the parents understand, 1 milligram is 1000 micrograms. So in inhalers, the doses are actually in micrograms, so much lower than milligram, which is generally the doses in syrup forms. Am I right, Dr. Vaidya sir?
Yes, absolutely. In
Yes.
syrup, it may be in more than milligrams. It may be like,
Correct.
for example, a syrup is 10 or 20 milligram, that is 2000 microgram versus 100 microgram in the inhaler. And
Right.
that too, 2000 going into the stomach, into the circulation. Here, 100 going only to the airways, hardly going into the circulation. So a very big contrast.
Right. And Dr. Vaidya sir, so these are generally the two groups of medications. So can you give us a quick understanding?
So what is a reliever? A reliever is a firefighter. It will put out the fire. Means it will open the airways. It will also, therefore, by opening the airways, it will reduce the wheezing and give temporary relief. What is a controller? A controller is something that will prevent the fire. It will prevent the inflammation. So it goes into the airways. It acts on the airway, reduces the swelling, and prevents the swelling from coming on again and again. So a controller is a long-term medication. A reliever is a short-term medication. So whenever there is asthma, you need to use a combination of these as your doctor advises.
Right. Great. So we have understood what kind of medications we are using. We understood that the doses are really, and parents do not be afraid if you learn that there is a steroid. All right. Moving ahead. So, Dr. Archana, won't these inhalers lead to body being addicted? Every time there are symptoms, body would need this.
So, first of all, the word addiction is completely wrong. I would say that, let me give you an example of a diabetic patient. A diabetic patient needs insulin, and without the insulin, it's difficult to control the diabetes. Then, can one say that the patient or the person is addicted to insulin? No, that's not how it is. So, when a person or a child needs a drug which is to be taken with proper dosage in with the advice of your doctor, obviously there is a certain course that we need to give, and your child needs it. That doesn't mean the child is addicted to it. It is needed, hence it's being given.
Right. All right. And Dr. Vaidya sir, what about child's picnic and school trips or even sleepovers? We also want to take our child for family vacation. So if there is an episode of wheezing or cough there, how do we manage that? Can we use the inhalers in all such situations?
So the first thing I'll say is that one, it is up to us not to allow my child's asthma, my child's disease to rob him of a normal childhood. No, every child is entitled to a normal childhood. And by using this therapy under supervision, under inhalers, every child can do all these things. They can go on picnic, they can go on trips, they can do every single thing. If a child gets breathless on playing, there are inhalers which will prevent him from being breathless. So it really reduces exercise induced symptoms. And many of these
Will be coming.
devices, especially in older children, are what is called as dry powder inhalers, which are
Right.
very compact, very easy to carry, and the child can be easily trained to use them even on picnics or school trips if the child becomes symptomatic. So I think no problem is there in terms of this, and your lifestyle should not be interfered with. And we do have devices that will enable a normal childhood for your child. Okay.
Right. So, in fact, Dr. Vaidya and Dr. Archana would tell us they have seen so many patients, slightly older children, who are so well trained in using their inhaler with spacer and mask or with spacer and mouthpiece that they take it well, they take it beautifully, and they continue with their activities. Um, Dr. Archana, can my child enjoy sports and follow sports at professional level, or let's say swimming? Also, there is a parent who has noticed that her son was very sporty, but recently she noticed that he gets very breathless on running, on physical activity, and she hears wheezing sounds also at times. What could this be?
So, answer to your first question, can the child enjoy sports? Yes. We just mentioned we want them to have a normal life, and for a normal life, whatever needs to be done in terms of good training, good medication, good nutrition, all that needs to contribute to it, and definitely can have a normal life. Of course, everybody who is part of this sports community needs to be informed that this particular child has this issue, and if there is an emergency they should be able to handle it. So that's all that needs to be done. Second thing about this child who is very sporty, and only when he plays or she plays, the child gets symptom. About 20% of children or people can get symptoms only when they play, and
Right,
this is a condition which we call as exercise induced asthma.
right.
So what happens when you exercise? Should I go ahead, Amrita?
Yeah, yeah, please.
So what happens with exercise-induced asthma is when one starts exercising, you are breathing fast and you are taking in air very rapidly into your passages. So this air can be cool air, and you immediately start irritating your respiratory passage. So about 5-10 minutes later, these children start coughing, they experience chest tightness, they start wheezing, they get very short and short of breath, and they can't participate the way they want to. So this condition is called as exercise induced asthma. The way to deal with it would be to have a proper warm up. When you have a warm up, you are allowing your respiratory passage to slowly get in the warmed up air,
The
and
adaptation.
the adaptation. And you can these children are also prescribed some short acting inhalers which dilate the respiratory passages half an hour before the exercise. They should also have a good cool down, they should hydrate well, and a good proper exercise routine, proper training. If that is done, these children have an excellent life in terms of their
Right,
competitive sports as well.
right. Dr. Vaidya, my 6-year-old has been on inhaler therapy pretty regularly for past 1 month. After it was started, first 2 to 3 weeks, he was actually so much better. But I noticed last week he has again started to cough, and I feel these inhalers are not being effective. What should we do?
So I think the whole key to that is regular follow-up, regular assessment. What happens is that the child must have been better for some time, but a fresh trigger must have acted, either
Right,
in infection or some trigger in the environment, and the cough has started again. It only means that the dose has to be readjusted, the technique has to be reviewed. So it is my policy in my clinic that whenever a child is on inhaler, I ask them to get the inhaler and spacer every time so that we can actually supervise the technique. And you'll
right,
believe me, lot of mistakes occur in the usage. Either the child is unsupervised, or in any way creative mistakes occur, and you have to again and again keep on checking. So one is review the technique, or sometimes up or reduce the dose or change the drug, and again visit the environment, look at the environmental factors which may be causing this trigger, and something what we call as comorbidity. Sometimes there are other problems that the child also has, like for example, allergic rhinitis, or a child may have something called a reflux or obesity, and
What
these
is
factors may
allergic
be.
rhinitis? Can you explain that?
Allergic rhinitis often coexists in children with asthma, almost to the tune of more than 50 to 70%. What is allergic rhinitis? Is nasal allergy. These children get blocked nose, stuffy nose, they may get mouth breathing at night, and in severe cases, they may get adenoid hypertrophy and what is known as obstructive sleep apnea. So essentially, it is the upper airway that is getting allergic symptoms, and because of the blockage of the airway, the child's wheezing problems are also aggravated. So both have to be addressed simultaneously to get a good response here.
Right. So, Dr. Vaidya, sir, what you essentially said is that on every follow-up, the doctors are actually assessing, adjusting the
Yeah.
treatment, and reviewing the response
Yes.
to the past couple of weeks. All
Yes.
right. So, parents note that regular follow-up is essential, and all of these things are assessed during that. Um, Dr. Vaidya, sir, one of the tool that the pediatricians advise nowadays is a symptom diary. Can you elaborate on this? How does this help?
Yeah. So I think
Isn't it an added work to the parent?
Yes. So actually, I agree with you that assessment is like a homework to the parents. You know that because when I ask a parent who comes with maybe after a month, that tell me how many days was your child having symptoms, and obviously even I wouldn't remember. Nobody would remember that. So the best way is to make a diary of this nature, where you have a few, just a very few simple columns. The first column is date. The second column is any symptoms in the morning. Tick that box. The third column is did I use my relieving inhaler? Tick that box. The next column is was there any nighttime disturbance or not, and the last column is activity induced disturbance. So activity induced cough. If it is not there, there is no homework to be done. Don't fill any box. If it is there, just prepare that grid and tick it off, so that when you come to your doctor for a follow up after a month or whatever, you know at a stretch how the child has behaved, and that empowers you to change the treatment very rationally. So I think this diary is extremely important. In fact, many of my older patients, they keep the diary on their own and they proudly display it as if it's a homework which they might display to the teacher. I think that's the culture that we have to inculcate. So there
Right.
has to be a good record which really helps in management.
Yes.
And the
So
other one is the
parents,
peak flow meter, but I think if you
yes,
want
we will
to.
be coming to that, sir.
Yeah.
So parents, please note, symptom diary is a great tool, and as Dr. Vaidya just now emphasized on, it's an empowering tool both to the parents to follow up on the child's response, and also for the pediatrician to be able to monitor the therapy. We'll come to this peak flow meter point slightly later. Dr. Archana, uh, my doctor has prescribed inhaler for 3 months without a break. My doctor has written, do not stop, even if the child is better. Why so long?
So, Amrita, before I say anything, can you hear me? Because I
Yes,
just
yes,
left
ma'am.
the meeting
You
and
are
I
very
joined
much
again.
audible.
Can you see me as well?
You are
Yes.
very much visible also. Please go ahead.
Thank you. Okay. So, why I want to take a bit of time for this is that let me say I want to build a house. If I want to build a house, I have to dig a foundation. I have to dig a foundation. Then I take time to construct the framework, the walls, and the ceiling, everything. So the inhalers that we prescribe, especially the steroid containing inhalers, which are called maintenance inhalers, to start their action itself, they take 2 to 3 weeks. So the foundation building itself is 2 to 3 weeks. After that, they take a little while longer in order to reduce the inflammation, to change things in the respiratory tract by which the respiratory tract is less responsive. So obviously, this much time is required. And of course, this is not, don't listen to what we say. Please speak to your doctor. And the duration of therapy is completely on prescription, and you cannot decide it on your own. But minimum 3 months is required without a break for effective treatment.
I think review is most important. And
Yes.
so we encourage you that it's not a case of fill it, forget it. Go every monthly to your doctor, get reviewed, and change things, and also supervise the inhaler device.
Parent who has asked this question, please note that it is prescribed for 3 months, but there is also a rider down there, follow up every monthly for reassessment. All right. Dr. Vaidya, I'm coming back to you again with a point that we mentioned in the symptom diary. Is there any way I can understand if my child is actually doing better on inhaler therapy? Should I only observe the symptoms, or is there something that I can do?
So this is a nice device which can be used for children, say above 6 to 8 years. Some of them even 6 years can do it. Now this is like a thermometer. You know, if you have a fever, you will like we are more comfortable with objective evidence. So we look at the thermometer reading or we look at the BP reading. So similarly, this is your airway reading. How does it help? This peak flow meter tells you how much air is trapped in the airways. Why is it trapped? Because your airways are in spasm. So if you can blow out a good amount of air, it means your airways are free. If you can't, it means that air is getting blocked inside, and it's an indirect evidence that there is some block in the airways as a result of wheezing. This beauty of this is that sometimes the airway reactivity reduces even before the child's even before the child has symptoms. So, especially if the child is on two inhalers and the symptoms are not there, but the peak flow rate decreases on a given day, you can abort the attack that the child may have by starting a relieving inhaler in advance. So, this is a beautiful method, and it is something that every child can be trained, especially above 6 to 7 years. I
Right.
think every parent should. It's a very inexpensive device also, and I encourage all my patients to use a peak flow meter as a good documentary evidence of what is actually happening to their airways.
It's
Right.
like a thermometer for the airway.
Yeah.
Absolutely. And hence, we had mentioned that in a symptom diary, along with what the Vaidya sir had described, peak flow meter, when you're using for your child, the readings, daily readings can be entered there. So we understand a pattern. Am I right, Dr. Vaidya sir?
Absolutely. You can add it to the diary
Yes.
and maintain the peak flow. Yeah.
Dr. Archana, my 5-year-old had to be taken to the hospital emergency department twice in the past few months. You know, we had a pulse oximeter from the COVID days. We were actually using the pulse oximeter and monitoring his oxygen level, but it showed almost normal, or probably we could not understand. He's now on inhaler therapy, doing better, but that really scared us. You know, in future, is there any way I as a parent can prevent this flare up?
So, first and foremost, pulse oximeter. While using a pulse oximeter in a young child, you can go wrong many times. Their fingers are small and the regular pulse oximeters are unable to detect. And very often you can get a normal reading in a completely breathless child. So please refer to what we said earlier about detecting breathlessness in a child. Okay. So all those points are to be taken into consideration. And when your child is on inhaler therapy, there are certain methods by which we tell you how to deal with the situation until you can get help. And there are ways in which you can come to know that your child is going to have a flare up, and the peak flow meter is one of them. We prescribe our patients something which is called as the asthma action plan. And in the asthma action plan, of course, please remember that this is individualized. It cannot be that I use my plan for some other child. It is individualized because every child goes through a follow-up, and on a follow-up only, we will decide the plan. So if your child is in the no problem zone, as mentioned here, you continue to do what you are doing. If the child comes in a problem zone, we may even ask you to take the inhaler at more frequent intervals, maybe 2 puffs or 4 puffs every 20 minutes or 30 minutes. That's the problem zone. And the emergency zone, when the child is extremely breathless, unable to talk, cannot walk or play, starts looking bluish, you do what has been told. There is some emergency drugs which are mentioned, and you have to rush to the hospital while continuing your relief inhalers, means the way they have been said. So this plan is given to all the patients so that you don't land up in a situation where you don't know what to do and your child has some help.
May I just
Yeah.
add one
Yes,
comment
sir.
on the peak flow meter, on the pulse oximeter, is that it gives you information too little and too late. If the
Yes,
pulse
absolutely.
oximeter is showing any problem, if you wait till that, your child is already sick. So do not rely on the pulse oximeter to reflect the gravity of the situation.
So can we say together as pediatricians that we are not recommending parents to
So,
use pulse oximeter?
no, we are not. Pulse oximeters on home use are not very accurate, as Archana already mentioned. The fingers are small, it may not give a true value, and any change in the pulse oximeter reading in asthma is often very late in the day. So do not
Absolutely.
have a false sense of security because your pulse ox reading is good. You have to look at the clinical features and even possibly the peak flow. Okay.
Right. So as Dr. Archana has already mentioned, parents do not get worried about this busy slide. It's not meant for you to read every point. Please focus on the central zones. This is going to be a tailored plan for every child by the pediatrician, and you will have it along with the prescription of the inhalers. So before moving ahead, let's again quickly summarize. Inhaler with spacer and mask or an inhaler with spacer with mouthpiece is the optimum mode of therapy when we are talking about recurrent or frequent cough, breathlessness, or asthma. Nebulization, especially at home, is not recommended. It can be risky for the reasons Dr. Vaidya has explained beautifully. Correct technique of using the inhaler and spacer. Symptom diary, peak flow meter reading for older children 6 years and above, regular follow-up with your pediatrician, optimum healthy nutrition and exercise. Together, all of this form the asthma management. Red flag signs, understanding where it is something much more serious, and having the asthma action plan understood well. Knowing where these two things is being prepared. All right. So moving ahead, Dr. Archana, I have a pet cat at home. You know, my child had really insisted, so we've got a nice, lovely pet cat. She's very, very cute. But I have noticed that my son has started sneezing and coughing much more frequently since this pet has come up. You know, this is an afterthought, but is there any way I can confirm if my son is allergic to this cat?
So, cats are particularly known to be highly allergenic. Their hair, particularly, is known to be allergenic. And it could be that this child is allergic to the cat because there's a complete relationship. As soon as the cat has come, your child has started sneezing and coughing. But yes, there are ways in which we can confirm because big decisions are to be taken after this. So, there are tests which are called as allergy test. The most important and gold standard is considered to be the skin allergy test. Here, tiny quantities of the allergen are put in droplet form on the child's hand, and with a prick, you just prick the skin and look for a positive test. A positive test will look like this, red and itchy. So skin allergy test is one good way to find out whether child is allergic to the cat or any other thing like dust mite, pollen, and many other allergens. There are some tests which are blood tests. Pardon me? The skin allergy test.
We discussed the allergens, yeah. We
That's
discussed
right.
allergens some of the things. Yes,
Many of the allergens which are there, inhaled allergens and some other food allergens as well. There are other tests which are blood tests, which are called the specific IgE tests. And there are many more advanced tests which have come by which we can, further confirm and go into the depths of the causes of the allergy of the child. But of course, these have to be interpreted along with the symptom and the history of the child. You could have a positive skin test, but you may not be allergic to that particular element. So don't randomly go and do these tests without prescription. Don't randomly put your child on a no wheat diet, no milk diet without your doctor's advice. That would be wrong.
That actually brings me to ask you this question, Dr. Archana. Are these allergy tests done as soon as the doctor starts thinking about a particular allergy, or are they done a little while later?
So there is no need to wait. If you are very strongly suspecting a causal relationship between the symptom and what the patient is saying, these tests, especially the skin test, is a visible proof for the parent to see that there is a probable problem. But like I said, just seeing a red test or a elevated wheel over there doesn't necessarily mean the patient is allergic or the child is allergic. It has to be correlated with the symptoms, the history. That's extremely important.
So I think, Amrita, what were you asking is, are these the standard of care or mandatory? The answer is no. They are not mandatory. They are not the standard of care, but definitely it has to be done based on the individual patient. As Archana said, there are patients where it's really necessary and you do it over there, but not as a mandatory thing for everybody.
Yeah, if there's a relationship, only then. Otherwise, you can't just do random tests for everybody. You have to be sensible about it.
Yes. So parents again reinforcing the fact that symptom diary, where you have a column where you can, put down your observations of triggers that will really help us understand your doctor understand what are the most common triggers and if any allergy test needs to be done. And kindly do not ask for random tests anywhere. Especially there are certain parents who say that there is a blood test. We have done that and it says it's a normal allergy level. Please understand it's your pediatrician who would advise you correctly. All right. Moving ahead.
Dr. Amrita, Dr. Archana, and Dr. Vaidya, we have crossed 1 hour plus,
Yes.
so we would need to
We are
wind up a
coming
little
to almost the fag end of the
Great.
webinar, ma'am, with 3
Let's
4
give
more
some time
questions.
for the questions also. Yeah.
Yeah, so we have to have some time for questions. There have been quite a few
Yes.
questions in the chat box.
Yes, yes. So quickly moving ahead, Dr. Vaidya, are there any tests to actually confirm the diagnosis of asthma? Can you just quickly give us an overview?
I'll just say in one word, there is a test called spirometry, which is possible only for children above the age of 6 years, and that test actually gives proof that there is asthma. There are
Right.
tests for smaller children, but they are not freely available. So as a practical thing,
Yes.
tests only above 6, and
Okay.
freely available spirometry. Yeah.
Right. Dr. Vaidya sir, one more question for you. My child has been very regular with the inhalers, but I have somehow noticed that he is quite weak, gets tired very easily, and is not really gaining weight. So, what could be the issue here?
Yeah. So I think let's remember one thing, that if we are going in the wrong direction, we should take a U-turn. If a child really has asthma, he is not going to have all these symptoms. He's going to be much better. So if a child is not putting on weight, not growing well, he is tiring very easily, then there is something else to it. So I think that is where the whole idea lies, that you have to go to your doctor regularly, get reviewed, and sometimes there may be a completely different diagnosis which may come up later on. Idea is to follow up and review regularly, and then you can come to this diagnosis.
Absolutely.
Yeah.
Dr. Archana, are there any early signs to monitor if our infant may have a future risk of asthma? Also, we have many times parents thinking that, a mother who knows that she has asthma, but the husband doesn't have it, the father doesn't have it. So, is the child likely to have asthma?
So there are typically these children who you can actually say that they are likely to develop asthma. These children have something called as atopy or atopic eczema. Atopic eczema or atopic dermatitis is a skin condition where you have babies, especially around 6 months, 7 months, when you're starting with different kinds of foods, they will have these rashes on their cheeks, on their hands, behind their legs. So these are portals for entry for allergens, and these allergens make the child sensitized to these
Ayush,
different
I'm your
proteins, and then they can have symptoms because of that. So when we see children like this, they fall in the group of possible allergic asthma in the future. Talking about your second point, one parent with asthma, chances of having asthma in the child is 40%. Two parents with asthma, the chances of having asthma in the child is nearly 80%. So it really increases if the parent has asthma. So you can keep this child under the radar. This child needs follow-up, but don't be disheartened. There are solutions for it.
Dr. Archana, also tell us if, all of these, the young child with an allergic rash or an atopic rash, the child with eczema,
Archana,
are
a
they
little
going to
shorter answer because we are really people are
Yeah. So quickly, I'll tell you the early phases. You can have the skin rashes that I mentioned, along with food allergies. These children slowly go on to develop allergic rhinitis, like Dr. Vaidya just mentioned. And the later stages, they can actually the allergic rhinitis and asthma in the later stages. So this is the progression of the allergies in children. So yeah.
All right. Moving ahead, Dr. Archana, we have talked about this actually. So if we go over to the next, is there any permanent cure if there is asthma? Are there any immunotherapies available? Can you give us a quick review on that?
So a quick answer to this is immunotherapy is available if there is a clear indication that there is a particular allergen that is there. You try to modify the child's immune system so as to stop reacting to that allergen. These immunotherapies are available as injections given under the skin, orally, and under the tongue. It is a highly specialized form of therapy, which is to be done only by people who are trained for doing it.
All right. And the last question, Dr. Gauri madam,
Yeah.
I am asking Dr. Vaidya sir, are there any vaccines that can prevent asthma, and which are these vaccines?
I'll answer in very quickly. One is that asthma can be triggered by viruses. There is a flu vaccine, which is one of the flu virus is one of the main triggers, and we have a flu vaccine to protect from this trigger. So do use a flu vaccine. And there is an exciting new vaccine called RSV vaccine coming to India shortly. RSV is known to be one of the inducers of asthma. So I think young children should be given RSV vaccine when available. It will definitely help as a preventive vaccine in asthma.
Parents, what Dr. Vaidya sir mentioned, RSV is a common viral infection, respiratory syncytial virus, and there is a upcoming vaccine for that. So asthma is not necessarily,
I'm going to
it's a
now.
no bar to success. Okay. As far ago as when it was not even a diagnosis made as methodically with treatment available so systematically, great musician Beethoven, US president, one of the US president John F. Kennedy, and not far from us, Mr. Amitabh Bachchan, Priyanka Chopra, and famous sports person. I'm sure you all know him.
Beckham.
Yeah. The footballer Beckham, all of them have had asthma and they have yet been successful. So with this, I hand over to our host, Dr. Gauri, to give us the take-home messages and to take the questions.
Thank you very much, Dr. Amrita. Brilliant session by none other than Dr. Prakash Vaidya sir, who's really a pro, and Dr. Archana Kavalkar. Thank you very much. Let me just go through our take-home messages in a fast-forward manner. Yeah, Amrita, can you share the slide? Everything has already been, given to you in complete detail. So let's go ahead and say cough is a symptom and not a disease. It's actually a protective reflex. It's not a disease, and the cause of which has to be determined. A child who's less than 5 years usually has 4 to 6 respiratory infections per year normally. So take it with a pinch of salt. Asthma is a condition of the lung airways caused by narrowing, and it is triggered by allergens and other environmental factors which were discussed in detail, including the home allergen, the indoor allergens. Investigations such as spirometry and skin allergy tests aid in the diagnosis and treatment. Inhaled form of therapy is scientifically proven to be more effective and safer in that the MDI, which is the meter dose inhaler with a spacer, is a 110% better device to be used than a home nebulizer, which Prakash Vaidya sir has stressed upon. And a proper technique of the inhaler, if you have been prescribing inhaler, please go to your doctor with the spacer and inhaler and show him or her how it is to be used. And a lot of mistakes are made, so we can correct them. Using a nebulizer, as I said before, is a very risky thing, and at home, do not use it. Regular assessment, review, and follow-up with the doctor is imperative for proper control. A regular vaccination by the flu vaccine and an upcoming RSV vaccination, balanced diet, regular exercising, continued breastfeeding up to 6 months. We keep on harping on the fact that exclusive breastfeeding up to 6 months is a definite protective measure for not developing allergens. Avoidance of unnecessary antibiotics helps in preventing lung problems. Live with asthma, control it well, and live successfully is very, very much possible, as has been already shown by few slides of guys whom we know. I'm sure there are so many of us who are on inhaler and we are doing very well. Thank you. Thank you very much. I'm going to come to the questions. Lots of the questions have already been answered. There are a few specific ones. So let me ask Archana, what do you...
Dr. Gauri, I'll stop presenting the presentation.
Okay. Okay. Yeah. What are we going to be saying, Archana, if you can take this question?
Yeah.
If my child wheezes, coughs, and then suddenly vomits, what do I do in such a case?
So the coughing center and the vomiting center are very close to each other in the brain. So when anybody, it need not be a child, when anybody coughs a lot, and the signals go from the cough center to the vomiting center, you can vomit. So, pat the child on the back, see that the secretions are taken out from the mouth, because we are worried in a younger child if it goes into the lungs. That's about it. It's very much common situation.
Yeah. So someone has asked with the combination of CPM and phenylephrine, which has been now all over the news below 4 years, is it dangerous? I think it has been answered. Cough syrups, cough suppressants is not the way forward. Maybe we were using it as pediatricians earlier on, but we have now realized that MDIs, inhaler therapy is the way to go ahead. How long can I wait? My doctor has told me that my child is busy having a cough for 8 or 10 days. He's a 3-year-old and he coughs once in the morning, couple of times in the night. Do I have to start the inhaler or can I just wait ahead?
So coughing about 8 to 10 times in the day is normal. We consider that as normal. So if your child has been on examination shown to be completely fine, chest is fine, the child has been examined, no running noses and rhinitis, ear infections, etc., then that much cough one has to learn to accept can be normal. Anybody can cough that much.
Great, great. Prakash Vaidya sir, someone has asked, can I do homeopathy as well as can I do a steam inhalation for my little baby?
Yeah. One thing I'll say is that today treatment of wheezing and asthma is very on solid ground, and we know that we have drugs which will help your child without any side effects. So, having said that, we have full faith in the treatment that we offer to your children. But if you choose to give homeopathy in addition, I really have no objection. However, it probably, if this question may indicate some lack of full confidence in the treatment that we are already giving. However, if that makes you happier, please go ahead and give it. No objection to that.
But I would say, I always tell my patients that don't try to walk on two rails together. Choose only one.
Okay. Someone has asked a question that my child has adenoids, allergic rhinitis. We was given metaspray, was given Budicort. Still, my child is coughing a lot. Now, what do I do?
This child needs to be evaluated properly,
Yeah.
and it's not the kind of answer we would like to give on this forum.
There is no
think a
one-line
regular
answer to this.
follow-up. Maybe the child has been prescribed and the parent, for whatever reason, has not followed up very regularly. And then I agree, a specific answer cannot be given. So very sorry, please go back to your pediatrician. Yeah. And what about breathing yoga and pranayam? Does it have any space in the treatment of asthma? Prakash Vaidya sir.
Absolutely, very helpful. There are studies on this. So definitely we encourage our patients to undergo this breathe pranayama for sure.
I think we shall stop the questions here. If anyone, I think I have addressed all the questions. Actually, I did not have to ask any questions because Dr. Amruta, as a moderator, and Dr. Prakash Vaidya and Dr. Archana have answered all the questions which were put in the chat box and which probably we had in our minds also. So absolutely wonderful. At the peak, we had 75 plus participants. Thank you, everyone. Definitely our speakers and our moderator and all the people, my fellow pediatricians and parents who attended this. I'm sure now you are much better informed. Lot of our queries, lot of myth have been busted. Truths have been unveiled. We had started with this. The topic of the webinar was my constantly coughing child, myth versus truth. So I'm sure that all of us have gotten a lot of truths, a lot of cobwebs cleared from our brains, questions answered. If any more queries, you can go ahead and ask or DM your doctors. Should not have a problem in that. Few points has already been mentioned. Please keep a regular follow-up. Please don't self-medicate. Because you have a 10,000 rupees ka nebulizer, do not nebulize. It is not the way forward. So that is one extremely important thing that we should keep in mind. Keep your asthma diaries, a regular follow-up with your doctor. And we have said that Thane Academy of Pediatrics for the year 2025 have our motto as reach the unreached. So this was an unreached topic, and we as a team have decided that we shall definitely go ahead and have few more or many more such interactive webinars where we are going to have topics which may not have been discussed in detail. We have brilliant speakers with us. So I do think that in case you have any topics of concern in your mind, you may DM us. And we are going to go ahead with such more interactive webinars, and that is going to be our way forward. Some question about allergens in the air. I think that has already been addressed.
So,
that
Gauri
question.
madam, can I just
Yes.
make a comment?
Sure.
There is a parent, I suppose, Mr. Anil Kumar. He has asked if we can get a recorded version of this webinar today. All the parents, we will be very happy if you visit the Thane Academy of Pediatrics YouTube channel. We are going to put up a lot of programs, including today's webinar, soon on our website, where you can go and have a relook at the full web.
Not the
Yes.
website. We have a YouTube channel. Please go
We
to
have a YouTube channel on which
Thane
this.
Academy of Pediatrics YouTube channel. Yes.
So there have been lot of things which have been uploaded, and this also shall be soon uploaded. And this has been a very insightful session. I will make Prakash Vaidya sir, any concluding remarks you would like to give us?
I think you have said it all in a nutshell. So I'll not add anything to it.
Okay, all the parents who have attended, I'm sure are very happy. They've got a lot of message in the chat box. Thank you everyone for sparing a couple of hours on a Sunday morning, and have a nice, safe Sunday. And hope a lot of doubts from on asthma. A lot of myths have been busted, truths have been unveiled, and we'll go forward with this. Thank you very much, and we'll leave the meeting now. Thank you very
Thank
much,
you.
everyone.
Thank you,
very much.
everybody. Thank you. Thank you, my friends. Bye-bye.
Bye-bye. How do we leave the meeting?
You can stop recording, Anand.